This conference will now be recorded.
All right. Hello and welcome, everyone. This is Caleb from TASC at the National Rural Health Resource Center. This is the third webinar presentation for the Transition to Value Learning Collaborative. This week, the topic is Success in Healthcare Transformation Delivery Reform for Payment Reform. Delivery Reform for Payment Reform, Practice Transformation. I will just a couple reminders to everyone. Be sure to log into the external SharePoint web page where there's a good discussion. Thank you, Angie, and everyone else who's been participating in that discussion online. We really like that it's there and available for you guys. So thank you for your continued participation in that. If you still have not gotten access to that and need assistance, please let me know. Please utilize the chat feature during the webinar, or *2 will unmute your line for discussion, questions, things of that nature. Those are all of my updates. So just a reminder, we'll meet next week at next Wednesday at 2 o'clock Central. All right, Shannon, I think you're ready.
Thank you, Caleb, and welcome everyone. I'm happy to see that you're joining and participating in this, like Caleb said, third in a series of 6 about success in healthcare transformation. As you know, the center is focused on 5 areas, and we've probably talked about it every week, but just to make sure, we're talking about transition from value to value in population health. There's also a collaboration and partnership, performance improvement, health information technology, and workforce. It's a great center for you guys. This series, as you see, we have 6, and we're moving to talk about practice transformation. Following this one, we will do a little bit of a detailed dive into hierarchical conditions, category coding. Then we will do return on investment on value-based care, and then wrap it all together about the big picture. The context for this week is that I want to continue building on the first 2 webinars, again, making a statement that CMS has a compelling reason to transform. We tried to highlight that in the first one and then really talk about what that does and how it looks like to CMS, in particular in population health. And in the second webinar, my point was to show that population health can help actually grow your primary care. And so to continue on that theme, I want to this week dive in a little on how we can implement primary care and what does that look like in a rural practice. So let's just see what we have. Last week there was a couple of questions about the homework, so I took your comments to heart, and I've actually posted this on the SharePoint. But what I wanted you to know is that the purpose of the exercise really isn't for me. Obviously, it's for you. And my goal is to help you create a good dialogue of exchanging what's happening in your communities, and then being able to actually develop those dialogues with the peer community. That is very specific in the primary care area, especially that's where population health is delivered. So this would be specific to questions to the primary care practices. One of you asked who would be who you would talk to get the questions answered, and I would tell you that if you're speaking with a critical access hospital that owns the clinic, anywhere from the CEO or the CFO or even the quality improvement manager might know the answers. If that's not the case, then you would want to talk directly to practice managers if at all possible. So the questions I outlined, the other request from you was that could we have all the questions in one group? And so I made an attempt to be very clear on what I thought the value of the questions would be. The first one is to reach out to 5 or 10 of them and determine if they're doing value-based contracts or programs. So you understand that the value-based programs could be with Medicare, the merit-based incentive payment system, or the alternative payment model, such as participating in an ACO or accountable care organization, or in the Comprehensive Primary Care Plus program. Those are both alternative payment models for Medicare. Providers could also be participating in commercial payers and value-based payment programs. They might not call them technically value-based payment programs, but for instance, a Medicare Advantage plan may be paying the practice to do some documentation about a specific process that they want to see be done in order to get their star ratings up, for instance, smoking cessation or something like that. And they actually pay for those services. So you might be able to ask, do you have special incentive payments with your Medicare Advantage plan in addition to your regular payment methodology? Then once you get past that, if you find a practice that actually answers yes to any of those questions, find out how many Medicare patients they have on their rolls. When I say on their rolls, it's interesting to know that they would probably come back to say, we want to know, are you asking how many Medicare patients we saw last year? And I think that is a narrow question or a narrow answer. We want to get the broad scope of how many they think are still active Medicare patients on the books, not just who they've seen in the last year. And the reason for this is that this will help us determine what the opportunity would be if they were going to provide primary care services. For instance, they might have only seen 300 Medicare beneficiaries, which were the sick of the sickest in the last year, but there may be another 200 or 300 out there that only come in once a year, or not even once a year, but haven't done it in the most current year. And if you can get that question answered, find out how many are actually providing an annual wellness visit. And what their concern will be is, generally speaking, they're going to traditionally provide an annual physical exam, which is, I think, the code IPPE. And so that's a physical exam, and that's not the same as an annual wellness visit. And it should be the initial annual wellness visit that is allowed, or a subsequent annual wellness visit that is allowed every year, paid for every Medicare beneficiary with no copay. So that's an important piece. And then last, ask if they are doing hierarchical condition category codes. So if that is the harder question and you're not comfortable with that at this point, then I think that what we will do is expand these questions for you to have time to speak with these communities wherever you find them, and not answer all of those questions up until week 5. So that gives you 2 weeks from today to actually have time to get comfortable about what you're asking. And as you're thinking about this, and I saw a great script that someone put on the SharePoint. If you have questions about that, I'm happy to answer that, and I'll be pretty active on the SharePoint from now on. So feel free to just post out there, and I'll keep an eye on it and answer for you. But this should give you some time to have a dialogue, and again, I think that this will roll into a script specifically how I wrote it. Hopefully that's the case. And if you do get a pushback, feel free to reach out to me. Does anybody have any questions on that? And if you do, please just go ahead and put them in the chat box, and I'll watch to see, making sure that I've answered your questions and requests for those questions. And seeing none at the moment, I'm going to go ahead and move to the next slide. So the other 2 things that were raised in the last webinar was, is it triple aim or quadruple aim? And so I went back to look at that, and remember, the triple aim was better health, better care, lower cost, and all of this based on the total spend of Medicare population. I've spelled it out a little bit extensively on this slide to the quadruple aim, and I'm trying to tie all of this for you in regard to these new programs are tied to transformation. But the transformation means not just you're going to get paid different. They want you to behave differently in the delivery. So what does that look like? What is their intention on that? So in better care, that really is a delivery reform. They're asking for processes and specifically focused on prevention and wellness. They've also given a new code in the last 3 years, that CCM code, or chronic care management code, that is really talking about extending the coordination of care across the delivery continuum. So this is new. They haven't paid outside the 4 walls of a practice or a hospital or a facility. And that is the beginning of delivery reform. They actually want to see a different way in which providers are behaving. And lower cost, keep in mind that's that total patient spend. We talked about that before. The average of total patient spend in the country on a per patient basis is anywhere from $7,000 to $13,000, almost $14,000 now, dollars per patient. The median is around $10,000. And so what they're wanting to do is change that number based on your own number. They don't want everybody to get down to 7,000, because that would change the culture in a pretty difficult way and could crumble some of the systems. So what they're saying is bend the curve and you're against your own benchmark. And then, of course, in the payment reform, they are giving payments for care coordination and also for annual wellness visits. And we're starting to see, the addition of telehealth this year and behavioral health last year. So they're extending on the things that they are paying for that they have not, or they're actually refining and improving those payments. So that is how they expect to have lower costs. Those things that they're paying new for is part of bending the curve and lowering that total spend overall. The result of that is they want to see, based on your provider's documentation, is an outcome and a result. And so that means that there has to be some incorporation of better access to primary care, and that truly actually is a delivery reform. I have it under here as an outcome or a result, but they want better access to primary care, real-time information for the chronically ill, and then have the result of that being reduced preventable admissions and preventable duplication of services. Finally, the delivery reform, and this is the fourth now of the quadruple aim, and that is regarding physician burnout. Forever we've seen the transactions of how many patients can a doctor see in a day, not how well can they take care of them. And part of the program in population health and what we talked about last week, and we'll do that in implementation in just a few minutes on practice transformation, but this idea of physicians and staff being burnt out is that the transaction is that they're just reacting to care and not really having the ability to have a time to deliver the care that they want to for the patient. It causes burnout and frustration. If we're able to have clinicians operate at the top of their license and supplement that with another layer of nurses or even medical assistants, then that helps to extend the provider's ability to give the type of care that they want to give, spend a little more time with the patients who need a little more time. So that's the quadruple aim. And then before I move on, I'll also say that there was a question about chronic care management billing, and I did go back and look, and the amount is 20% of the charge, generally speaking, or about $8. That could go up to that number that you talked about before because there's more than one type of chronic care management. There can actually be 2 or 3, depending on the severity or the need of time spent under that CCM, which really relates to the severity of the disease state. So hopefully that answers. I did upload 2 documents that are the quick facts for Medicare that talk about what it takes to run chronic care management and the billing process connected to that. So hopefully that's support for you in that information. So let's talk about how to not just get a different kind of payment, but to how to receive or receive payment based on a different kind of delivery of service. I think what's interesting is that up until the last 5 years that I got into this space, everybody felt that meaningful use and PQRS were add-ons to your job that you already had. And I think that a better way to think about that is retooling the work that you do rather than just keep doing the same thing and adding one more. So again, that's reform, delivery reform in particular. And so it's divided up into 3 buckets today. The first one is workflow and process. Literally, how do we consider changing the order of things that we may do and what processes are in place to support those outcomes that we talked about in the quadruple aim. The second one is prevention and wellness, and certainly we talked about population health as a program, but then how do we implement that with the workflow and processes in regards to the services connected to that. And finally, in order to get paid properly and to recognize the value of the work that you're doing, there has to be really correct, proper coding, documentation, and reporting. So those are those three buckets. The first one is really about changing the practice workflow to support the quadruple aim. And these are the high-level processes that we see in the field. The first one is addressing the care gap. When we speak of care gaps, that's really talking about patients not having access. So, for instance, if you have a patient that's a CHF patient that has a very quick rise in weight gain and they can't get an appointment that day, it's very likely they'll go to the emergency room. There needs to be a care opportunity for that patient on that day real time. So one of the things is, how do you actually change the practice in order to work in slots to be able to manage the care of people who need it that day, rather than getting the provider further behind and all the patients that had appointments having to wait. So you have to figure out how to address care gaps. And we'll try to talk about that on the next slide, but not going too deep on the dive today. The other one is you need to use data to inform the process and continually improve the process. It's interesting that you could pull a list of all of your patients on a specific disease state and then identify what those problems are and determine if there's something that needs to be addressed before the patient comes, when the patient comes in. So someone working in population health that knows the services that you as a practice would be delivering, you would be able to say, I want to run all of the diabetic patients, and or let's run all of the patients who have 2 chronic conditions listed this year and see if they're eligible for chronic care management. Let's see how many they have. Then when the patient comes in, if you know they're coming in that day or that week, you can actually have a conversation with the doctor to refer that patient to the chronic care management program. But that's a process that's probably not in place if you're not doing chronic care management. You're not actually mining data that's in your own electronic medical record. And that brings us to the next step, obviously, which is to have necessary IT infrastructure. Certainly you need to be in an electronic medical record, and there needs to be documentation of those disease states so that you're able to actually run those reports. I mentioned already, identify patients who are at risk. There's more than one risk. The idea that, and we'll talk about this in the hierarchical condition coding, category coding, but it gives the ability to see patients who need to be checked in on specific disease states that have been recorded but maybe not had some sort of diagnosis and treatment for them. That is all rolled up into what we would call pre-visit planning. So having the ability to, for every patient that comes in that day, to see if they've had their annual wellness visit, and if they haven't, then schedule them one. Also to look and see if there are previous year diseases that had been mentioned but not mentioned in this year that need to be documented in order to demonstrate, again, the severity of the disease state. That gets back into the hierarchical condition category coding. And then finally, one of the things that's really important in this day and time is that each practice needs to build a clinical relationship with their patients, all the patients, not just those that are sick. Maybe those just entering into the senior population maybe only have wellness visits, and what if they decide to go elsewhere to have a wellness visit? What if you were seeing them because they had the flu and they wanted to come in and get their flu shot? Go ahead and talk to them about getting an annual wellness visit and schedule them to come back and do that. That's sort of start building the relationship proactively instead of thinking they have to seek out someone to help them. This is critically important because everybody's doing this, and everybody is seeking to build a primary care relationship. This is connected to alternative payment models. When providers are in alternative payment models and they get paid based on the outcomes of patients, those patients are attributed to that measurement based on the primary care, specifically in the accountable care organizations, which are the primary alternative payment models that we're seeing in the country. So capturing your patients, making relationships with them even when they're not sick is critically important to keep them as your patients instead of losing them to another system that wants to capture. So, push the button too hard. So some of these are just notes about this. The workflow changes that we just talked about, use data to manage patients, do pre-visit outreach, actually communicate with the patient before they come, give them the reminders. How would you then do workflow changes if the patient's only going to see the nurse? Are there rooms that are available in the practice to do that? If they're not, what's the logistics of the handoff? This is a conversation that the practice manager and the nurse lead and physician lead would really need to work on that. Then there actually is the process of bringing the patient that is only seeing the nurse. You know, this goes from a culture of having patients that are used to coming in for when they're sick and then having a physical exam attached to that versus coming in and having a whole series of wellness visits that a patient could have that may or may not be seeing the doctor. And that's not a one-time event. It takes a while for the patient culture to change to accept that as a possibility too. So there's the facility issue of space. There's the relationship issue between the physician and the patient and how comfortable they are, and then where does that nurse fit in and how does that also work in the workflow with the practice manager. So then there's handoff issues. This really leads to the point of the role of the care coordinator. What I saw in the last 5 years of talking about getting people to become care coordinators is it's a unique thing for a nurse who has been very used to working directly under the direction of a physician in a clinic or in a hospital setting. This is a lot more leeway to a nurse, and sometimes that's just not what they're looking for. So it really needs to find someone that wants to be in that role, to be able to do some creative solutions. Nurses are so awesome and evidence-based that this sort of creates a little bit outside of the evidence of, okay, how do we do this? And it really needs to be somebody who wants to take that role on. Not to say that any one of them can do it, but some of them don't want to change. I saw that a lot. Could the care coordinator who's doing chronic care management also do the annual wellness visit? And this goes back to the number of Medicare beneficiaries you have and how big is that program actually going to be. I just spoke about the type of work for that nurse. There's also then the issue of that the physicians need to trust that nurse in order to do physician huddles with the nurse when the nurse is doing chronic care management and a care plan arises that the nurse needs to go back to the physician. There's a workflow that there needs to know, are they going to text each other? Are they going to email each other? Are they going to meet collectively in the practice? When does that happen, before or after, you know, an appointment, middle of the day? That just needs to be figured out of what the workflow existing works. It can't necessarily be prescribed from someone externally. It's very customized. And then there's also a workflow change of where and how you do the documentation for the care plans for chronic care management. This is a module that not everybody purchases, and so it might be that the nurse doesn't have a laptop or a tablet to be able to document that, because the facility, the practice itself is set up just for people that are seeing patients seeing doctors. So where is the IT for that type of care plan? So that is a lot of things to think about on workflow changes. I'm telling you this because this is some of the things that you're going to see people wildly successful for that, and some people who really don't even know how to figure this out. One of the great things about where you all sit in the Flex offices is that you will be able to develop peer communities, those who are leaders in particular areas based on these conversations, and those who need help in particular areas. So I'm hoping I can help you identify those areas, and then you can find some on both ends of the spectrum and connect them. So the next one is actual annual wellness visits. And I didn't do a whole lot of detail on this, so what I would like to do, and I'm sorry, I thought I turned my turned off my Outlook so it wouldn't come in and bother us today, so I apologize for that. So one of the things for annual wellness visits, when a provider is in an annual wellness visit, it also needs to have a certain kind of process flow. You want as much information as you can get from that patient. If you remember when we saw the color chart, the heat chart of red and green, there were two of them, one with the 6 ACOs and then one with actually one particular site. But the majority of that information came from an annual wellness visit. And those documentation of that annual wellness visit in the proper place actually translates to quality measures in some places, depending again on who the payer is and what the program is. But if you do this annual wellness visit extensively for Medicare, this values all the way across the commercial spectrum as well. So it's important to have a very robust program when you're doing annual wellness visits. There are also other billable services such as the advanced care planning, and I'll show those in the next slide. And then when you're in the annual wellness visit, you'll be able to refer to follow-up services if they're identified there to the physician to then be able to refer to the patient. On the care coordination, one of the things that has to happen in workflow and process is the billable side of that. It's different for rural health clinics than it is for fee-for-service clinics. And how that works might be a little different based on scope of license in every state, based on who's actually doing the care coordination. So that needs to be done at the very beginning in order for there to be a return on investment. It really helps to nurture and help the care coordination nurse. There's a lot of burden put on that person because it becomes a billable service, and there needs to be a lot of documentation in the outcome and the value of the program. Again, the ability to have peer communities for nurses like that, and then the people making the decisions about setting that up also is very valuable. And then we talked some last week about using nurses to extend the services for both of these as a nurse-led population health program. Goes back to that quadruple aim. actually operating to the top of the license, helping the physician be able to manage the chronically ill while still having time to see everyone and not just those that have a disease state. Also helps the practice manager be able to find a slot. It is predicted that with a Medicare population, in order to deploy this, you're going to need at least an hour more on the schedule for every Medicare patient. So doing that, you may not be able to recruit more physicians to do that, and the return on investment wouldn't be as good as if you had a nurse doing that under the direction of a physician. So these are the revenue opportunities that are billable services, specifically in a fee-for-service. There are some that you can do in the rural health clinic, and that's a whole other conversation. So I'm not going to go into great detail, but as you can see here, there's the IPPE, that's that very first one, initial preventative physical exam. That's the one that you normally see in rural health clinics because the billable is the same for them. It's an all-inclusive rate. And they still want to do diagnosis and treatment in that physical exam. They can do that in one. And an annual wellness visit takes a lot longer. It is really a survey, and so they don't generally have the time to do all the intake of that. So that's why the nurses need to do that. And they can have both of those, the annual wellness visit and the physical exam. When the senior is entering into Medicare, they have a one-time only in the first year, an initial visit, and then from then on it's a subsequent visit. They also can add on to this as advanced care planning, and then all those things on the right, the preventative health screenings, depression screening, alcohol, drug screening, assessment and intervention on alcohol and substance abuse, BMI above normal, I believe that's intervention. And then there's behavioral therapy for obesity, tobacco counseling, and then DSMC training. That's a one-time event that then goes to the diabetic self-management training. We also now, you see on this list on the left, has remote patient monitoring, telehealth, originating site, facility, billing, integrated behavioral health, transitions of care, chronic care management, along with those first four that I talked about. None of these are excessively easy, but if done right with proper workflow and process, you can retool a practice to capture a lot of these without having to start over and from scratch. So one of the things I'd like to do is, if we get a list, if you find a practice, if you find that they have value-based contracts, and even if they're not doing value-based contracts, if you call 10 and you don't have any, or if you call 5 and that's all you can do, still find out the number of Medicare beneficiaries they have and the number of annual wellness visits, not IPPEs, but actual annual wellness visits, and either kind, initial or subsequent. Then what we'll do is try to put some numbers to that. And I'm thinking that what I will ask is the Friday before that 5th week that you send me a summary. Next week I'll kind of give you a little table that you can send it in, and we'll try to do calculations so that you can actually see some of the value of that. So then there's coding, documentation, and reporting. And when I say code claims properly, it's not that people are not good coders, but one of the things that has happened in this adoption of electronic medical records is that there are a lot of customization when you buy an EMR. you incorporate it into the existing workflow. And the minute that you start customizing the EMR, it sort of unwinds their inherent built-in queries for specific things that are industry trends. So you might want to run a test to say, you know, how many people that you did on smoking cessation. And if you've created a separate template that's outside of the norm that you like, that you're using, that wasn't incorporated into those standard queries, they're not going to show up. This is a sidebar, funny story, a little personal, but my daughter was running a large practice and participating in an ACO that I was with the company that was working with the ACO, and we had said, okay, we're going to, you know, do the interaction connection with your data feed between the EMR so that we can get the data into the data warehouse and run the numbers. And on more than one occasion, she would call very frustrated and say, we've done all these things and they're not showing up and it's all your fault. And the reality is it's a very frustrating situation with technology on you don't know to ask and they don't know to tell, or the other side doesn't know to ask and you know to tell. It is a iterative process of submitting the documentation and checking to see that it matches what you know to be true when you're looking at the chart. And so this is a, you know, not an immediate result. When you adopt doing measurement reporting, it doesn't come out exactly, you know, oh, let's do it. Okay, we're going to do 3 times of practicing in this, and then we're off to the races. It's a long process. It's a year-long process. So it's really, really important that you recognize, or that your practices recognize that this is not an immediate result. It's something that you have to work at and get to know and figure out what that problem is if it's not showing out. 2 important things also about proper documentation. If you have a patient that doesn't come frequently, or if you have a patient that has multiple disease states but only presents with one frequently, the corporate knowledge that you have in your EMR does not carry forward year after year. So what that means is if a patient, and again this is a brutal example, but it's the most clearly used, is that if you have an amputee and you saw that person in 2016 about the amputation, and in 2018 everything is moving along and you're just dealing with other complications but not particularly that one, it's not going to show up to the payer that this person has an amputation, because they don't keep that. You need to, every disease state needs to be recorded every year. Now, it doesn't mean you have to bill for that, and it doesn't mean you're up-coding, but it means it's proper documentation. The reason why is in the future, based on this value-based payment initiative, is that they're going to tie the severity of the disease state to the resource use. And so if you're just billing diabetes, but your diabetic patient has retinopathy and neuropathy, and that takes a lot more time, you're only going to get paid for taking care of an early diabetic person and not someone with complications. It's critically important that the information is included in the bill and in the documentation in your records. So I think I've switched these and already talked about the right place. The other one is the quality payments are tied to actions. The quality payments are identified to actions that are connected to quality measures. And you're not going to get the quality payment if you're not tracking that connection. So what might happen, the result of that, is that if your EMR system does not have the capacity, and I keep saying you're assuming that I'm really sharing with you what you would be able to say to your practices, so forgive me for that. But if it's not translating, you might have to do some manual reporting. There might have to actually be some need in which you're going to dig in and find out where it's going. That, of course, would lead to getting it to the point of documenting in the right place or figuring out how you do that. But you need to be prepared that when you're doing quality measures, that your technology isn't always going to serve you, but you're still going to be held to the requirements. So with that, what I want to say is that this transformation, and as we move forward, is really a change across the entire program of healthcare. It's from curing disease to keeping people healthy. It is moving from transactional diagnosis, treatment, and cure, or volume of services, to actually prevention and wellness, quality, cost-effective services. It's moving from fee-for-service, which is transactional, to outcomes or value-based, so it's activities, processes, prevention, and wellness. And then it's also moving from the doctor of the center of authority, which is a heavy burden, to having the doctor be the center of the care team. Now, the great news for all of this is that primary care starts a lot in rural communities. And if anything was really good that rural communities do is integrate and become an integrated delivery system with about 75% being outpatient services, prevention and wellness, and primary care. So the opportunity for rural communities to be very successful in this, I think, is huge. It has to be posed in the position that it's not something to add on, it's something to transform to, and that there is a good way to have financial success to it. So that ties to the myth that we talked about last week. It's not necessarily bad for a rural hospital to be in a rural health clinic. It's not, whether you're, not in a rural health clinic, to be a rural hospital and a rural health clinic, to be in an accountable care organization. Yes, admissions are going to slow, but will that some portion of slowing actually be filled by all the other things that you've been informed that you can do and offer with the primary care services and the data that you're receiving on doing the primary care services? So I encourage you to say that engaging in transformation is positive, and if you don't, it's a huge negative. Commercial companies are all in the process of doing value-based payments. One of the things I will focus heavily on in the week 6 is to be able to help you understand all the things that are happening that are either, one, available, or two, the result of rural hospitals not participating in value-based payments. Because we've been paid on all-inclusive rates, it's very difficult to report quality. Because we're cost accounting, and historically cost accounting was more than 50% of our revenue platform, what payments we received. That was how the majority of work was driven. As Medicaid moves to Medicaid managed care and Medicare moves to Medicare Advantage or into value-based payment for alternative payment programs, or you are not participating or exempt in NIP, so you're not doing the one way that you could increase in payments, you're not going to get increases in payments, and you may actually get decreases in payments across the spectrum, which will ultimately harm the very basics and existence of rural health care. So it hasn't been the drive of rural health care, but the platform is starting to change, and the opportunity for change is available now. The opportunity to change the positive is very huge. It just has to be engaged in this transformation. So I will talk more about the industry trend and how that relates to rural in week 6. So with that, I'm actually going to get to the point of questions. I finished a little early today. Does anybody have questions, or they have thoughts about what they would like to know? If there's any particular topic in regard to what I have been offering you in these 3 webinars that you would like to have some expanded time on, I might be able to work that into 5 or 6, week 5 or 6, to tie that into those 2 topics, either return on investment and or the big picture results matter. So any thoughts, or if you don't have any now, please just put those out there on